Hi everybody, so it's Dr. Rashmi Kudesia with CCRM Fertility Houston back again for part 2 of the Shakti Collaborative Reproductive Empowerment series. And today we're going to talk about demystifying PCOS or polycystic ovary syndrome. We had so many requests to talk about PCOS as part of this reproductive empowerment series, and I'm not surprised. Actually, to talk about the relevance of PCOS in the South Asian or South Asian American community first, which I briefly touch upon in the blog post, so please check that out. It is incredibly common in our community, and I'm going to talk about kind of the overlap between cardiometabolic disease and PCOS, but in studies that have been done both in South Asia and including one that actually I did in the US, about 40-something% of women that present for fertility care that are of South Asian or South Asian American descent are coming in for management of PCOS. And so it is incredibly common. And so I'm not surprised that so many readers and listeners wanted to hear more. So today I'm going to just kind of run through the topics that we talk about in the blog post. And I definitely want to hear any feedback or questions because we're going to cover all of these topics in more detail as we progress through this series. So polycystic ovary syndrome in general, when we think about all women, is thought to affect about 10 to 15% of women, or reproductive age women. And that is based on the diagnostic criteria that we use. There are different criteria that have been proposed. The one that we typically use in clinical practice nowadays is called the Rotterdam criteria, and that was put forward in the early 2000s. That requires somebody to have 2 out of 3 things. So first is menstrual cycles that either don't come at all on their own or that are irregular, okay? And so a normal menstrual cycle or a regular menstrual cycle is one that comes every 21 to 35 days on its own when you're not on birth control. And so if you're having a cycle that falls outside of that window, then that may be considered an irregular or absent cycle depending on what your bleeding pattern is. So that's the first criteria. The second criteria is how the ovaries look on ultrasound. And typically what we expect to see there actually has nothing to do with cysts, and so it's kind of a bad name. It has to do with either how large the ovaries are or how many little follicles are sitting inside of the ovary. And each of those follicles presumably has a little egg that's growing inside of it, but the follicle is a fluid-filled sac we can actually see on the ultrasound and count how many there are on each ovary. And then thirdly, we look for either clinical symptoms or blood work that would tell us that maybe the level of hormones that we typically think of as the male hormones, but we all have them, like testosterone, for example, could be elevated. And so that can also present in a variety of clinical ways, like having acne issues, or most commonly having issues with extra facial or body hair. And of course, that's always relevant to kind of consider based on your ethnicity. So I'm not going to compare somebody with, dark skin and dark hair to a patient that is fair skin with blonde hair. It's very culturally specific, and we know that in general this excess presentation of facial and body hair we call hirsutism is most common among South Asian and Mediterranean women, and so that is the third part. And so if we have 2 out of those 3 criteria met, then we have the diagnosis of PCOS. And oftentimes we think about, well, when is the right time to make that diagnosis? And for reasons that I cover in a little bit more detail in the post, it can be difficult to make in adolescence, but many women that have PCOS will often present in their teen years having irregular cycles. And so sometimes it can be hard to make a firm diagnosis. I typically say that because so many of the symptoms can overlap with just being a normal teenager, and because it can take a few years for your cycle to sort of settle down into a firm pattern after you have your first menses. Usually we say that we finalize the diagnosis about 8 years after that first period comes. It may be sooner, it may be a little bit later, but typically by the early 20s, we should really know whether there's PCOS or not. And so if you're kind of floating around and you're not sure what your doctor's told you, or if you have this diagnosis or not, I highly encourage you to find a specialist to get checked out and finalize your diagnosis one way or another so you can be sure about what's going on with you. That's definitely part of the big message of reproductive empowerment, is knowing your diagnosis and then being able to make a plan to manage it. So when I think about how PCOS can show up, there's really 5 different elements or domains that I always focus on, and I've sort of derived that approach from an instrument, a validated survey instrument that's called the PCOS related quality of life instrument, or the PCOSQ. And what I like about that is it sort of describes in detail how there can be different aspects to PCOS that can affect a woman, and these change over the course of a lifetime. So those domains include the hirsutism that we talked about, so excess facial or body hair. It includes irregular vaginal bleeding or irregular cycles, infertility, weight management, and then also mood or emotional health. And so you can imagine that for a young woman in her 20s, maybe acne, weight management, irregular cycles coming at the wrong time, especially if you're in school, or a busy first job, could be incredibly important. And then maybe 10 years later, someone could be thinking about starting their family. The metabolism could be slowing down, and so weight management and fertility issues could kind of become a bigger issue. And, so these things can change over the course of a lifetime. And so it's important to know and keep reassessing which aspects are most important at any given time. And so to kind of briefly run through them, the first, as I mentioned, is the hirsutism. And so that's kind of the extrafacial or body hair. And I think it's important to note that sometimes we actually see a little bit of the opposite, or something that you might consider an opposite, which is basically male pattern baldness, or what we call androgenic alopecia. And believe it or not, these are both caused by the same thing, which is high levels of the androgen hormones like testosterone. And so, basically, if that is a primary concern, then there are different ways to manage it. But unfortunately, many of the best management options that are medical, as opposed to, sort of mechanical hair removal like laser, waxing, etc., which is what many women do nowadays. But aside from that, medical therapy often is hormonal. And so these therapies don't always apply when women are trying to get pregnant. And so that is an important consideration where you are in your family building plan when we think about a management plan for hirsutism. So know that there are many options: dermatology, reproductive endocrinologists like myself, or even a general OBGYN or primary care doctor or medical endocrinologist. Any of these specialties can probably help you get started on managing these issues, but you have to find the right fit for you. The next piece is incredibly important, and that's the irregular vaginal bleeding. It's important to know that if you're not pregnant, if you're not breastfeeding, if you're not on birth control, you should be having some sort of bleeding fairly regularly every 3 months or so. If somebody goes for a long, prolonged period of time without having bleeding, and none of those situations that I just mentioned apply, they're actually at risk for those uterine cells to develop precancerous and cancerous changes. So it's important that you don't just, not have a period for years and think that that's okay. So that's something to talk to a gynecologist or reproductive endocrinologist about, to make sure that you have a management plan for your irregular cycles. And that is relevant whether you're trying to get pregnant or not, because obviously we want to avoid endometrial or uterine cancers. And also we want to avoid what happens when we haven't had that normal sequence of hormones which comes from an ovulation or a release of an egg. And so if we're not having that normal pattern, then sometimes what can happen is that 3 months go by, and then all of a sudden we have what we call an anovulatory bleed, which can be a very heavy, very painful bleed that can sometimes last for months. And we see a lot of patients picked up in the emergency room for that because they come in bleeding very heavily, or they become anemic. And so these are things that you want to avoid. And so, that sort of preemptive management of how the menstrual pattern is going. And so that's something that's important as well. Fertility is a big issue, obviously my specialty, and we're going to talk about that in more detail in the future. But the main thing to take away is that PCOS does not make you infertile. I have so many patients that are told that at a young age, and it is not true. It's really important to come in and understand what your options are. But the good news is that, especially when you're young, treatment can be very simple. It can be low intervention. It does not require in vitro fertilization necessarily. So it's just important to understand how we manage that and to be as healthy as possible coming into the time frame when you're thinking about starting your family or growing your family. Weight management is another huge aspect of management. We know that PCOS can predispose women, regardless actually of where their weight is. It could even be in a healthy range, but it can predispose women that have PCOS to develop insulin resistance. Insulin is the hormone that deals with sugar we get in our diet, whether it's a cookie or white rice or white bread, wherever those carbohydrates come from. And so when we become resistant to insulin, it predisposes us to developing diabetes and so on. And so that's an important part of the management. And any doctor you see to talk about PCOS should really go into detail about your lifestyle and how we can optimize that so that you have the best health outcomes, over the course of your life. And finally, the last piece is emotional health. PCOS can predispose to anxiety and depression. So please make sure you have someone to talk to. You have a support network that is behind you all the way in managing PCOS. When you think about all 5 of these things, it seems very overwhelming, but the good news is that in one visit, we can really tackle a lot of these issues, make a game plan, and many of them kind of work together and can be addressed simultaneously. So don't lose hope. Feel empowered by knowing whether you have PCOS, how to manage your diagnosis, and how you can take your care forward in a compassionate and smart way. See you next time.